On achieving excellence with small incision lenticle extraction, as we use the term SMILE to talk about the small incision lenticle extraction technology of doing refractive correction on the cornea. This is something that's kind of taking over refractive surgery in a wave. Though it's about 10 years old, now it's kind of come of age, and world over, whichever center has started to do SMILE, in less than a year, SMILE has overtaken that particular center's LASIK load. So LASIK numbers drop and SMILE goes up. That itself is a proof of the efficacy of SMILE and the safety that is inherently built into the SMILE technology. So we have got very, very eminent speakers who are going to talk to us about one. I'm going to talk myself about the introduction to SMILE. Then we have selection, patient selection, evaluation. Dr. Atiq Ahmed will be talking about it. Sheikh Hamid, and the procedure of docking will be taken over by Dr. Ramya. And Dr. Rupal Shah is on the way. She would be talking about SMILE complications and management. An introduction to the latest technology in SMILE, known as SMILE Pro, will be handled by Dr. Aditya Varman. Hyperopia correction, which is the latest, which is not yet come out officially in SMILE, but a few months away, will be addressed by Dr. Sheetal Brar. So without wasting any time, let me get on with the introduction to SMILE. Okay, so now talking, is SMILE the ultimate procedure for laser vision correction? I have no financial interest in this presentation. Laser vision corrections have been around for more than 3 decades. We started off with doing PRK, went on to LASIK, went on to femto-LASIK, then went on to now lenticule extraction. So we've got many variations of these. So basically it all means all of these, whichever you do, does not make a difference. You're changing the corneal curvature to get rid of the refractive error. You have to approximately change the corneal curvature by about 0.8 microns for every 1 diopter that you're correcting on the spectacle plane. That means if you're correcting -10 on the spectacle plane, you're correcting 8 diopters on the cornea approximately. And this does not change. You cannot change laws of physics. So PRK, LASIK, femto-LASIK, SMILE was the way that we went. So what is the advantage of small incision lenticle extraction? So here you are making the refractive cut, both the anterior and the posterior, using the femtosecond laser. And femtosecond laser on the cornea is nothing new. We've been using it to make flaps for for about 20-25 years now. So you're just making 2 cuts and pulling out the lenticule through a small 2 millimeter side cut. This incision can be as small as 2 millimeters or large as 4.5 millimeters. So advantages, it's an even treatment zone, which I'll go on to prove to you. On excimer laser, it is not possible to get an even treatment zone over the total 6.5 millimeter treated area. It's only in tissue extraction using the small incision lenticle extraction technique that the treatment zone can be even end-to-end on the whole 6.5 millimeters. So why is that? So that's the question to be answered. When you make a drastic statement that excimer laser can never give you a proper ablation profile, then we have to prove why. That's the cosine effect. In excimer laser, we've all been doing excimer lasers, LASIK, PRK for 30-35 years. We all aim for a 6 millimeter or a 6.5 millimeter treatment zone. But always the treatment zone is 9.5 millimeters. That's a transition zone that we've been told has to be there to prevent edge glare. No, that's not true. Absolutely nothing to do with edge glare. It is to do with the fact of laws of physics. You are forced to give a transition zone of almost 1.5 millimeters on either side, totals to 3 millimeters because of the cosine effect. Excimer laser can only be delivered through mirrors. It cannot be delivered through fiber optics. So you have to have a particular distance away that the mirror stays so that you can work under the microscope. The shortest distance on the machines is 17.5 centimeters, that's on Vuzix. The longest is 22.5, that comes on the Alcon platform. So approximately 20 centimeters is the distance between the cornea and the mirror. And the mirror cannot move sideways. The moment it moves sideways, it is out of focus. It's simple, the focal distance changes. You can only tilt. Agreed? Fine. So you have a beam that is usually 1 millimeter or sub 1 millimeter. Most machines today are on a 0.65 millimeter diameter of the spot size. We'll, for argument purpose, take it as 1 millimeter beam. When the central area, now if you're treating 6.5 millimeters, when you treat central 1 millimeter, second shot to the other side, it is 2, third shot is 3. That means you need 3 shots on each side to get a 6.5. Agreed? So when it falls vertical, the 1 millimeter beam gives you an area of 0.785. Wonderful. The moment you go to the side, next shot, 1, the mirror tilts. 2, the cornea is curved. So the treated zone becomes oval. So your fluence drops down. So you're treating a larger area with the same energy. So now from that, it goes to almost 0.8. Now you go to the next one. Third, you're down to 0.92. So what happens is that treatment of 4 diopters at the center will only give you, at the 6 millimeter edge, will only give you 2.75. To move the 4 across right to 6.5, you have to overlap, do more shots in the periphery, less in the center, and then proceed on to do a transition zone or blend zone on conforming to the laws of physics. No other choice. You don't stop at that edge. You just can't. That's not the way the machine is going to work. That's where the laws of physics put you a stop to your own algorithms. And this is something that we've never thought about, never understood. And when the company guy says, sir, we're trying to get rid of the edge glare, and we all nod at our heads. No, it's to do with laws of physics. So coming back, another law, which is misunderstood. Why do we get poor treatments in higher powers in LASIK? When you do a treatment zone of 6.5 millimeters, up to about 3 diopters or 4 diopters, you actually get 6.5 to 6 to 6.5. As higher diopters are treated, again by laws of physics, you will be getting, if the effective treated zone becomes shorter, smaller. So on a -10, instead of getting 6.5, you would hardly get 5.5. And that is why in excimer laser, the higher powers treated, you have poor results. If you want to treat -10 and get the same results, then you have to go to a 10 millimeter or 10.5 millimeter treatment zone. That's the total zone. So from 6.5, you go to 7.5. You'll be eating up tissues, which is not possible. So we've been always trying to cut corners with excimer and not getting to the best refractive outcome till date. While you have to, what we do with the excimer laser, we all know that the accuracy of the depth of placement of the cut by an excimer laser is somewhere between +2 to -2 microns. So if you want to place a cut at 110 microns, it's going to be probably 2 plus or 2 minus. That's the maximum. So if you're talking about a 4 diopter misalignment, which is the maximum that is possible, when you're talking something like about 13 microns of tissue for diopter, 4 microns means about an error of 0.3. 0.3 diopters is the only inherent error that can come in the femtosecond cut. And the 2 cuts, the deeper cut, refractive cut, and the superior cap cut are measured perfectly from the surface of the cornea by the applanation cone. We all have got phenomenal accuracies when we raise a flap with the femtosecond laser. 110, you get 110. 100, you get 100. 90, you get 90. 100%. Rarely you're off by 2 to 4 microns. That's about all. So imagine that accuracy that comes in here. And then, because there is no question of the measurement is from this corneal surface, there's no cosine effect. There's no difference between the cut or the position of the cut at the superior or the inferior, whether in the center or the periphery. You get an even treatment zone up to 6.5. So it doesn't matter whether you're doing 0.5 or you're doing 10, you get precise results with excimer, with lenticule extraction. And this has been proven. There are studies which show you that the treatment zone evenness somewhere about 35% higher than you would get with the best excimer lasers. That's been proven by studies. There are no questions on that again. Then what else is the advantage? Biomechanical stability. The anterior corneal stroma is considered to be much stronger than the posterior corneal stroma. So you have got the anterior corneal stroma is only cut at the side cut 2.5 millimeters. So the corneal biomechanical stability is better maintained with SMILE than with excimer laser. When you do XML laser, the flap lifts up, so the anterior corneal stroma plays absolutely no role in the strength of the biomechanics. Number two, the dry eye symptoms are much reduced because the amount of nerves cut comes down tremendously. Yes, still you get nerve cut there. It's not that it's completely free of nerve being cut, but it's much lesser than it will be occurring with the XML laser, whether it's PRK or XML laser used with a femtosecond flap or a mechanical flap. Disadvantages. You have to come. Everything has disadvantage. Of course, SMILE is more expensive. It's a little bit technically difficult. It's not that it's impossible to learn. Anybody can learn it in probably about 3 or 4 days, particularly if you're already doing femtosecond flaps and you're learning how to lift them. And all the more if you're a cornea surgeon doing lamellar surgeries, it'll probably take you 2 days to do it, nothing more than that. But of course, when complications occur like a torn lenticule or retained lenticule, things get a bit hairy. But in every of these conditions, there are safe bailout methodologies which will still give you outstanding visual results. The second way of the problem was cyclotorsion compensation. We are all glued on to having the axis of correction of the cylinder to be absolutely perfect. When you do XML laser, yes, you have iris registration, limbal vessel registration, and you can kind of come on to that. With the femtosecond laser lenticule cut, until now, there was no way that you could do that. You could do it, which is off-label. You mark the cornea, and then you put the patient under and turn the cone, which is not what the company recommends. So there was an issue, particularly with higher cylinders, in getting perfect accuracy. Not anymore. When we go about talking about the newer machine, we'll tell you how the newer machine, the VisuMax 800, you can do perfect alignment. Now, at this point of time, it is done manually, but very soon you would have absolutely automated alignment that's going to come on, where the data is taken from the IOL Master 700, transmitted to the machine, and that uses the limbal and the iris marking to position the axis of treatment. So we've done a study on SMILE. I'll just go through it very fast. What we want to show is the absolute accuracy that you get. Postoperatively, 100% patients got back their uncorrected visual acuity, which was same as their corrected visual acuity preoperatively. We did not have anybody that had anything less than their preoperative corrected visual acuity. So that's an absolute thing of the accuracy. And nobody lost any line of vision. That's the proof of safety. So you're talking about safety one end, other one the accuracy. It scores very high on both. So we look at the way that the spherical equivalent is clustered around. This is actually a dream graph. To get this kind of tight clustering is the dream of every refractive surgeon. And that's where we are. So that comes in by the technology itself. There's nothing that the surgeon is going to do on this other than getting perfect refraction and doing perfect centration during the procedure and doing a procedure that is atraumatic. So concluding, SMILE and outcomes are phenomenally good. They are very safe. They are more in tune with using the laws of physics to give you the best results. So the standard settings are the machine, the company gives you a setting of around 30, which is the laser offset, and a spot distance of 3 microns and a track separation of 3. With experience, you go down lower, you use lesser energy. We use a laser side cut energy of only 22 offset. A spot distance is much further, 4.5, track distance of 4.5. That means your energy levels drop from 150 nanojoules down to 110, where recovery of vision is immediate. In 6 hours or to 8 hours, the patient gets back to 6/6. So that's earlier in the SMILE protocol, higher energy settings, cost, delayed recovery of vision. It could take a week, sometimes 2 weeks. That doesn't occur anymore. So what is new in SMILE? I will just go back. And the drawbacks, again, we told you. Pupil centration has been done manually now. The newer machine that is automated. Lack of cyclotorsional compensation. Again, that has been addressed in the new machine. Now, hyperopic correction is not available so far, but we are a few months away from hyperopic correction coming onto this platform. About the newer machine, I will not talk about it because it's already going to be covered by Dr. Aditya. I'll skip these. So is SMILE the ultimate? As of now, probably it is. So significant improvement over LASIK, addresses all the issues of LASIK. Most important, we should not forget that all the complications of LASIK are related to the flap. There are a whole page, you can write out a page of complications or related to flap. All of these are out of the window the day you start SMILE. There are no more flap-related complications at all. So that really makes a big improvement. So is SMILE the ultimate? It probably is. Thank you.
Yeah. So the next speaker will be Dr. Atik. So he'll be going through the process of selecting the perfect patient to undergo a small incision lenticle extraction.
Good morning, everyone. Yeah. The workup of SMILE is no different from any other refractive surgery. It's more or less the same. I think anybody who reads topography and people who do who do refractive practice, most of us will get this. It will be sent via WhatsApp. You get a picture of the topo and AR, and we are asked whether can we do refractive surgery for this patient. Well, topography and AR, with this you cannot take a decision whether any refractive surgery can be done. So that is the take home I want to give. So this is something very important. History and evaluation are equal, at times more important than just looking at these two results. Though it is boring, you need chair time, you need to talk to the patient. Age is absolutely important. A patient with a -5, -1 at 25 years, how you will correct the patient is totally different when the same patient is 36 or 37 plus. Occupation of the patient, there are certain occupations where flap-based procedures are not allowed. So examination and history from the patient as to why they want to do the procedure also needs to be taken before giving options to the patient. This is how we get most of our patients. They want our procedure to be absolutely successful, absolutely safe, totally painless, lasts forever, never anything is got back. They want it right now, either free or via insurance. These sort of patients is what we get usually when it comes to refractive practice. What we have to understand is no procedure is 100% safe. Even if all parameters are within the green zone, all of us would have encountered at least once or twice a perfectly normal patient with a great residual bed going in for ectasia. So saying certain things like 100% safe, you'll be absolutely free of glasses is not the way forward when you're looking at a good refractive practice in the long term. So in these sort of patients who question more, you need to give them more chair time, understand what they're expecting. Patients in gray zone, better to use simple vocabulary, ensure that they understand, give them realistic expectations about the procedure, and then go ahead. This is something that another issue. This was a patient was sent asking whether refractive can be done, and the question was refractive surgery done? Yes. Does the patient have a flap? No. So again, these sort of things we cannot take a call just looking at the topography. Examination is very, very important. And refractive history, when the power started worsening at younger age, more in favor of KC, above 30, pellucid margin degenerations can be considered. So stability for at least 6 to 12 months is very important when we are considering refractive procedures. Soft lenses preferable to be off at least for a week's time. Otherwise, it can cause changes in corneal thickness, irregular astigmatism, and also false positive or false negative values. Dry eye is something that's very important. Again, it gives absolutely haywire, irregular astigmatisms. It gives us wrong K readings. So dry eye is something that needs to be evaluated. Hyperlacrimation at times gives an image of an ectatic disorder. This is a patient who is having lacrimation, and you can see the K is around 54.2, and you can see that the tear meniscus is quite high. So these sort of patients, you need to treat the MGD or the dry eye. If possible, give a small window period for this to settle down, call the patient back, redo the topography, and then take up the patient for the procedure. Rubbing is something that's very important. Ask for history of allergy. So in these sort of patients, SMILE definitely has an add-on because there is no flap, and flap-based complications are negated. General history from the patient. Diabetes, we need to be very keen and properly ask the patient. Most of our patients who have diabetes, you ask them, do you have diabetes? The answer will be no. But they will say, I'm taking medicines, it's under control. So according to the patient, they are not diabetic, but this again needs to be properly taken into consideration because diabetes can cause a myopic shift. So any patient with high blood sugar levels, we need to wait for 4 to 6 weeks for it to settle down, ensure that the refraction stabilizes and then taken up. Same applies for hypertension too. We need to be cautious. Patients with allergy, patients on antihistamines having dry eye, again we have to be careful with the workup done because we will be getting falsely estimated topo and we may be giving more rejection. So these sort of patients we need to be cautious. Patient with collagen vascular disease, always safer to avoid these patients. A negative workup of Sjogren's is very important. They can be considered provided it's just a mild disease and TBUT is normal, we can go ahead. Again, SMILE is preferred over LASIK and flap-based procedures. Pregnancy and nursing, very simple answer, better to avoid any procedure during pregnancy because the corneal biomechanics is totally changed. The rigidity of the cornea is lost. The cornea is more flexible courtesy estrogen. Same thing applies for patients on hormone replacement therapies. Anybody on estrogen or progesterone, we need to be very cautious. Mainly estrogen affects the corneal biomechanics. Antihistamine just said that it causes dry eye, and patients on antidepressants and anxiolytic, it is very difficult to make the patient lie down, dock and do the procedure because they are not that very cooperative. For refractive surgery, you need good cooperation from the patient side to get good results. Steroids, again, a lot of changes happen. So patients on steroids is better to be very cautious. Family history of KC, again, very important, mainly at least first degree relatives. You need to take that extra time out of those patients, be very cautious, careful, do a proper evaluation, and then take up the patient for surgery. Refraction, something that's extremely important. A proper cycloplegic refraction needs to be done. JCC should be used to confirm the magnitude and the vector of astigmatism. Last time I heard Adit and Arul sir saying that they no longer check the patient up to 6.6. They are dropped still further to analyze what the patient is capable of reading. They even drop down to 6.5 and 6.4. That is absolute BCVA is calculated. 6.6 is not the ultimate what we can try. So that definitely needs to be considered. Ocular surface analysis, usually only dry eye is considered as an ocular surface disease. Definitely it is not. We need to consider the ACRS OST algorithm. Look for the lids, do a BUT. If you have access, NIBUT definitely has advantage over it. Evert and see all patients to see for any allergies or bullae. Do a meibomian gland expression, press the gland and see whether you're getting clear fluid. At times we'll be able to see pus-like fluid coming out. Again, they affect topography values, and the corneal surface also drying will be a little difficult. Those lipid sort of things comes immediately when we put the speculum. So treating it and then taking up the patient for surgery is something that's very important. Patients with eccentric pupil, better to avoid refractive surgery. Glaucoma is a gray area, again better to avoid refractive in these patients. Fundus examination should be normal. So basically, good stable refraction at least for 1 year is very important. A few slides on topography. So to begin with, the quality indices, it has to be normal. Check the quality specification, ensure it is okay. Sometimes when we have the yellow zone or if it is red, it indicates that either the patient has moved or a small tilt has happened. So before we read or interpret the scan, ensure that the quality specification is fine and then go ahead with estimating the values. At times we will be able to see multiple dots on the topography. This indicates that the lid was not open and the machine has extrapolated the values. So these sort of cases always encourage the patient to open the eye widely, repeat the scan and then go ahead with interpretation. So checking quality specification is as important as knowing how to read the corneal topography. K reading, first thing you want to check is if it is less than 46, it's perfectly safe. If it is anything above 46, you have to see it with little bit caution. More than 48 is definitely a red flag. Inferior asymmetry is something what we are looking at the 4 mm zone, difference between the superior and inferior areas. If it is more than 1.5, it is considered as a red flag. Superior steepening, though not very common, at times we will be able to see it. At about 2 to 2.5 is considered a red flag. Again, sometimes we get false superior steepening sort of picture when there is a tear accumulation just below the lid margin. So that needs to be checked, and we have to ensure that that is not there. That is where clinical examination is important. Just looking at topography and giving results is a little, that's not the way forward to analyze. Skewing, again, it indicates or is commonly seen with ectatic corneal disorders. So skewing of more than 21 or 21 and above is considered a red flag. Skewing less than 20 degrees can be considered okay, provided all other parameters are also fine. Abnormal shapes, when we see the elevation maps, either island or tongue shape extensions are red flag signs. Along with this, other parameters also needs to be checked. When we look at the anterior elevation, some studies say cutoff of about 12 is okay. Some people go up to 15 to 20. So to be very safe, anterior elevation less than 12 is absolutely safe. Posterior elevation less than 17 is safe. And more importantly, when we have a big difference between the anterior and the posterior elevation, we have to view it with caution. Difference of less than 7 to 10 is okay. When it is more than 10, we have to view it with caution, because usually ectasia starts in the posterior surface and then comes towards the anterior surface. Pachymetry thinness point less than 470 is normally considered not okay. So about more than 500 is definitely safer. Then the coordinates of thinnest location, again less than 0.5 is safer. More than 1 is a red flags line. Then the difference between the thinnest point and apex, same value of less than 0.5 is considered to be safe. Then the Bade display or the Berlin Ambrosio ectasia display, look for drop in curve. When it is, you have to see for how much the curve is dropping within the 6 mm zone. If it is very significant, again it has to be viewed with caution. The lazy S or the curve where it is shooting up and moving up, we have to view it with caution. So pre-procedure, aim for a residual stromal breadth. Initially when you are starting maybe with around 300, you can drop down even up to 280 or 270, but again that needs some expertise and you have to be totally perfect with reading your corneal topography. Thank you so much. I just want to say one thing. Clinical examination and history is definitely has to be included in our workup. Just viewing the topography and then saying a patient is fit for surgery is not the way forward. Thank you.
Thank you, Atik. That was very, very nice. We'll take questions at the end. We have now Dr. Ramya Sampath, who is a very experienced laser refractive surgeon. Has got large volume experience with the smile also. She's going to talk to us about procedure, execution, docking, and the ideal way to extract the lenticule.
So good morning to all. So as you all know, smile has been increasingly preferred as a mode of treatment for myopia and myopic astigmatism owing to its enhanced patient satisfaction, better ocular surface stability, biomechanical strength, safety, efficacy, and predictability. SMILE has been US FDA approved and CE Mark II. So this is the SMILE 500 kHz CAR-Z system, which consists of the computer unit, laser arm, microscope, which has been integrated with different illuminating systems like diffuse, lit, and IR, and the vacuum system, the patient supporting system or the bed, which moves up, down, forward, and reverse, and a foot pedal. The important steps in the SMILE or any lenticular extraction would be docking, femtosecond laser application, lenticule dissection, and lenticule extraction. So as you all know, I'm talking about the 500 kHz SMILE or the first generation, which has a longer suction time of 25 to 28 seconds. So it is important for beginners to choose your patients properly. You should avoid choosing patients during your initial curve with difficult orbital anatomy or with uncooperative patients. Preoperative preparation becomes very important. The patient should be adequately counseled and informed consent to be obtained. Topical antibiotics to be instilled prior to surgery. Topical propafcaine 0.5% is instilled in both eyes to provide topical anesthesia. And it is also important to note that excessive instillation will cause black spots and epithelial loosening. So these are the treatment parameters which has already been elaborately explained by Sir in the previous talk. But I just want to know the cap thickness, although it ranges from 100 to 160 microns, based on the surgeon's preference is usually between 100 to 130. The incision width is planned again between 2 to 5 millimeter, which doesn't have a significant postoperative visual impact if you even keep a 5 millimeter incision width. The lenticular diameter ranges between 5 to 8, but the optical zone mostly is 6 or 6.5. The transition zone is usually for the cylinder or not for the cylinder sphere. The minimum lenticule thickness averages around 15 microns. So these are the different settings which are there, but mostly it's preferred for the expert mode for the surgeons where you have modifiable settings. The standard and fast mode doesn't have modifiable settings. In expert mode, the surgeon can modify the settings based on the patient response and the laser optimization. So this is the chart which has to be entered prior to docking. And this, if you see, the treatment pack size comes as small, medium, and large. Based on the white to white, it has to be selected. But for the Indian population, mostly we use the small size cone. So this is the treatment objective where the docking or the suction apparatus is fixed. So this is the sterile contact glass or the patient interface, whatever we say, is connected to the docking surface. And it is slightly raised for it to have the auto calibration done. The Visimax treatment pack consists as a pre-sterilized single-use disposable accessory. No cleaning, disinfection or re-sterilization is recommended. The treatment pack comes in the blister pack that has been already tested to maintain the sterility. So this is the contact glass or the patient interface. Once it's attached to the docking surface, we ensure that there is no contacting agent used with it or the liquid shouldn't enter the vacuum tube. The vacuum tube will be connected to the suction vacuum connection fixture to the other side. And we ensure that the centration as well as docking has a very short surgical time. And we also ensure the background noise in the OR is kept minimum when the eye is under suction. Once the suction apparatus is fixed or the contact glass is fixed, the patient supporting system will be moved. Before that, the vacuum system or the vacuum tube has to be connected to the connecting fissure on the laser vacuum system. And once the machine senses, the laser console senses the adequate pressure has been obtained, the ready mode activator indicates that the lights over there, which says that adequate suction has happened and now the eye is ready for the laser pass, and we press down the foot pedal continuously to have a smooth laser. So the sequence of events goes like the patient interface or the contact lens is first fixed. We connect the vacuum. The patient supporting system or the bed is moved up. The eye is applanated. The suction activated. We check for the LED indicators. Then we go ahead with the laser pass. Once the laser is completely passed, it has an automatic cutoff where the bed system moves on to a safe distance. The similar things is being repeated for the other eye. So this is just a pictorial thing where we see the centration is done, IR activated. The centration is basically done using the CSELR or the coaxially sighted corneal light reflex, and it creates the 500 kilohertz femtosecond system creates an intrastromal lenticule pocket where the posterior surface of the lenticule is created first, which is shown in the picture B, then the anterior surface of the lenticule cut, and finally the incision cut. So these are the recommended instruments, mostly the Chanceuse spatula, advanced lifter, and smile. So this is just an animation for us to explain about the procedure. The Sinski's hook is used to open the incision first. Then we prefer creating two pockets. I usually prefer to do the posterior pocket out to in, then the anterior pocket which goes out to in again. The posterior goes into out, the anterior out to in. The dissection should always be the anterior. We use the same plane, then we go back through the plane where we created the posterior pocket, and this we prefer doing it in the segmental sequential dissection method, where the lenticule closer to the incision is dissected last to provide the anchorage. So before docking, the speculum application becomes very important. Although the docking here is only corneal limbal suction, adequate exposure of the cornea is really needed. So we prefer using a bladed speculum like this to prevent the eyelashes coming into the treatment field. There are tapes available or a simple micropore to make the eyelashes away from the field, which is very important for us during the femtosecond laser pass. We do not want any kind of debris coming in contact with the contact glass. So that's the reason that we prefer the eyelashes to be away. So the docking is centered over the coaxially sighted corneal light reflex, nothing but the reflection of the green internal fixation light over the cornea. So once the femtosecond laser passes, you will ideally have a smooth layer of the femtosecond layer with two rings, the cap ring and the lenticular ring, and finally the incision cut. Here you can see there is an opaque bubble layer. Although the complications will be dealt in detail by the next speaker, I would just want to let you know, for beginners, it is important that you keep in mind thick corneas and thin lenticules will predispose to opaque bubble layer where you end up having difficult dissection. So this is how an OBL looks. Again, black spots are non-lasered areas due to entrapment of small air bubbles. So black spots and dry spots will again have difficulty during dissection. So these are non-lasered areas there, which will have a difficult dissection. Excess saline again should be avoided. The cornea should only be adequately moist, but you should not have excess saline, which will lead on to suction loss. So that's a case where we had excess saline, but we were fortunate enough that this case didn't experience any suction loss. So this is another case. Although the patient did not have excess saline, verbal anesthesia becomes more important more than the topical anesthesia. Some patients become really uncooperative during the laser. So you need to constantly make the patient calm and make them understand. So that's where we ended up having a suction loss during the middle of the procedure. So lenticule dissection, as I've already told you, there are two rings which helps us in which serves as a visual landmark for us to identify the plane and helps us in further dissection. So when you enter the posterior lenticule first, you'll end up having a cap lenticular adhesions. So to prevent the cap lenticular adhesions, we have different signs such as the meniscus sign, shimmer sign, and the white ring signs. All these signs helps us in identifying the correct dissection plane and to have a smooth lenticular dissection. So this is a video for us to let you know about what is the ideal lenticule dissection and extraction technique. As you see, the posterior pocket is created, but it is a small pocket. Then I've created an anterior pocket. and the dissection is done. Here, I would like to let you know about the importance of holding the eye or stabilizing the eye with a second instrument. For beginners, I would always recommend you to stabilize the globe, which helps us to have a better traction and control during the dissection time, so that the eye doesn't move away from the surgical field, and your dissection time also is decreased. So that is how the posterior lenticule dissection goes. In a segmental sequential manner, the last part is dissected out. And again, for beginners, I would recommend you to use a spatula, which will aid in complete dissection. Once the lenticule is removed, you have to place it over the cornea to check for its completeness. And the lenticule dissection, the extraction should be done again to a capsular excess method. We shouldn't forcefully extract the lenticule. You have different instruments to dissect. Depends upon the surgeon's convenience. You have different instruments. This is yet another instrument to do the dissection. The incision can be planned at 90 degrees or 120 degrees based on the patient's surgeon's convenience. Again, 2 mm or 4 mm doesn't cause a postoperative significant visual impact. Again, different techniques for us to explain when you have a cap, the lenticule which is attached to the cap. This has been described by Hamad and Fakri, where you use a Y-shaped instrument to push down the lenticule and extract it. And again, this is described by Professor Titya et al., an AIOCT guided method to identify it and extract the lenticule. Apart from this, we have various other modifications in lenticular extractions, which each having its own advantages and limitations. But for beginners, I would always recommend to go with the segmental sequential dissection method. So retained lenticule becomes a big headache for us. So initially, again, as I've already told, not to use single instrument, to go with only spatula. And during the dissection, ensure that you remove the lenticule again to a capsular excess method, so that you will release the stromal adhesions and remove the lenticule in toto. In this forceful stripping and extraction of the lenticule, have had some retained lenticular fragments which was removed in the same sitting. So that's the partial lenticule which was stripped initially forcefully. Then the retained lenticule fragment which was taken in the same sitting. So beginners, please ensure that you use a spatula and lenticular excess to be done for the extraction. Cap side cut tears and incision cut tears are very possible during your initial learning curve due to excessive surgical manipulation or excessive topical installation of anesthesia, which goes on with your experience. So, but all these things can be easily managed using bandage contact lens and doesn't have a significant postoperative impact. Excessive manipulation will end up having tears. So to conclude, SMILE has been increasingly preferred because of its precision and biomechanical stability. Patient selection becomes very important to have to provide optimal visual outcome. Novice surgeons should avoid cases with low refractive powers and difficult orbital anatomy. Identification of the lenticule edge is the important step during surgery. Lenticule misdissection is one of the most common complications which is encountered intraoperatively. As majority of surgeons are still adapting to this surgical procedure, various modifications which we have explained may not be universally applicable. Thank you.
Thank you, Ramya. That was quite extensive. Thank you so much. Now we have Dr. Rupal Shah talking to us about the complications. Now, though SMILE has been available commercially for about 10 years, Dr. Rupal Shah, I guess, has been working on SMILE for almost 15 years. She's the person who has actually done all the work for Zeiss on perfecting the SMILE platform. Almost 15 years back she started. All the ways that the cuts are being made and the energy settings for the cuts were all designed by Dr. Rupal Shah. So it's very, very gratifying to have you here. Talk to us about complications.
Thank you, Dr. Varman, and thank you for inviting me to be a part of this. Really comprehensive and good SMILE session. What I'm going to be talking about is complications and management. As Dr. Ramya already pointed out, it's a simple procedure. If you do it well, it does not really cause any complications. But every procedure do have their own set of complications. And if you know them, if you anticipate them, then you can also handle them well. And cornea, as you know, is a very forgiving part of the eye. And so if you manage your complications well, then there is absolutely no damage to the patient done. I am a consultant for Carl Zeiss. I do receive travel and research grant. So there is actually not complications with SMILE. I would tell them as special situations. Retreatment after SMILE is something that I think Dr. Ramya didn't touch upon, and I will just throw a little light on that, because complication can also be in the form of under or overcorrection and not the final desired outcome that a person has wished. Most times, complications are related to intraoperatively, and the commonest one is suction loss during the several femtosecond laser passes, and sometimes a lenticule getting stuck under the cap. So we'll just deal with those little in detail. As regards retreatments, we know that LASIK retreatments are simple. If it's in the early stage, you can just lift the flap and perform the excimer laser if you know how much is the bed and the flap quality. Some people prefer to make a new deeper cut. And also sometimes you can just make a side cut with a femtosecond laser and open the same flap or go on the surface. In SMILE, we don't have the luxury of a flap, so we cannot relift it. And therefore, what we need to do is do a surface ablation for doing a retreatment. But we also have a very good alternative in terms of a circle software, which can convert the cap into a flap. And then you can open it and run the excimer laser on the bed. This is important because if you just go ahead and do a surface ablation, then sometimes there is, the patient of course has more pain, greater recovery time, and they had wanted to avoid this in the first instance itself. Also, there are more chances of haze if you don't use mitomycin C along with when you are doing a retreatment with surface ablation over a flap or a cap. So it does become a little more complicated in that sense. And therefore, the circle software, which is a really nice and elegant way of converting the cap into a flap, is something that can be used. It's not as simple as you would think, because to get the same plane would require a lot of thought upon, and this is how it was devised. So the first studies on animal eyes were done within the Singapore Eye Institute, and this is the first circle software used in the world on a patient. So I would like to show you this, because right from the first cut itself, we could approach the same plane and do a treatment. And today I must have done about 45 uses of circle cuts, and every single time I could get to the same plane. What it does is, as you saw, it created a round of extra femtopulses beyond the SMILE lenticule. And therefore, it gives you enough space even to correct a hyperopic overcorrection. And you can see I'm being very tentative here because I was not sure whether I would be in the same plane. But to our great surprise and pleasure, it was very easy to open the flap and to get the same plane to finish the treatment. So you could use this. Uses of circle after that have been many folds. But before that, I would talk to you about the different stages at which you can get a suction loss while doing the procedure and what to do about it. So as you know, as has been really nicely described by Dr. Ramya, SMILE has various cuts. The first cut is on the posterior plane. This is followed by a side cut. This is immediately followed by an anterior cut. And finally, it ends as a small incision. So there are 4 femtocuts, and the suction loss can happen at any of these 4 places. So if you get a suction loss when you just started doing the procedure, if it happens within the first 10 to 20 microns, then there is no 10 to 20 seconds, and it has just started and you get a suction loss, then there is no problem. You can just go ahead and do it as a SMILE procedure. But if it happens like this, where you have already done the first pass and not finished the side cut, then the company recommends that you should not do it as a SMILE procedure, but gives you an option to do it as a flap. Because the first pass is very important. It is giving you the refractive result. So if you go ahead and do a SMILE cut again, it may not go to the same plane, and then you would not want to have under or over correction. So you can convert it into just a flap and do it as a femto-LASIK, as I've shown here. You do have this choice of going to whatever depth you want, however big you want. So just like you would do your normal flap creation, that's the way you do it. You should remember that the first pass is much posterior, and therefore your flap is going to be much anterior, and it would not really coincide with that plane at all. Coming to the next place where you get it after the side cut of the lenticule is made, and there are telltale signs. As you can see, there are some water molecules already on the suction, on the cone, the contact glass, and you can see the patient has started moving. At that particular time, you should try and tell the patient to calm down and to go ahead. But sometimes the patient is too nervous and starts fidgeting, and you can get a suction loss right at the end. Now, if you get it at the after the side cut of the lenticule is done, you could just go ahead and refit the contact glass like was shown here, and you'll find that you can approach the plane very easily. All these cases are the first 500 cases done in the world, and we didn't know exactly what to expect, and yet we've gone ahead and done this to know whether you get the same plane or not. But we had done a few femto flaps with the laser, and we did know that you can actually go to the same plane. This can happen if you go immediately. Use the same contact glass, because the contact glass leaves a footprint. So if you just go ahead and fit it again, then the footprint gives the contact glass now goes and fits into the same place. So you get the same centration. Also, if the pass has already started, it's the plane of least resistance, and therefore the next pass is going to go exactly in the same plane. I had done in a femto flap 3 times docking, because I got suction loss 3 times, and to my utter surprise, I had actually got the same plane. You can sometimes have the whole procedure done, and finally you have the procedure getting aborted at the final incision. It's very frustrating, because you would feel that, oh, you've just gone and touched the other end, but you have not finished the race yet, and you can have a suction loss like this. Now, if that happens, there is absolutely nothing to worry about. Your bubbles are still there to guide you, and you can use the infrared camera and know that your suction is correct, the centration is correct. You can see here I'm adjusting, making the patient look wherever, and then fixing the suction ring. And after that, it just creates a small incision through which you can approach the planes that you have done. So suction loss is not really a very big problem if you handle it properly. You should not get perturbed. Calm down your patient. Use the same contact glass. Make sure that you have the same centration, and you would not have any problems in the final outcome. So that's the take-home message. Sometimes it can be not such a rosy picture, and this is one such case where again we aborted the case at the final incision. Patient was very, very anxious. She was moving a lot. You can see right from the first pass that water is seeping into the suction glass. And just at the last moment, we got a suction loss. Now here you can see there is a lot of thick bubble layer in the center, which is not allowing us to really have a look where we are exactly centering. So we tried. Patient was also not able to look straight ahead. She could not. She was very anxious. And we still tried to get the correct centration. You can see dense bubble in the center, so we could not actually make out where exactly that green point was. And all the other bubble on the periphery was not there. So we did get a incision, but the incision was not connected to the plane inside. So we tried opening the incision, but we could not go and approach the plane. At this moment, rather than trying to make false passages, I would urge you just to leave it alone, or to go ahead and do another incision little more inside. Here what we did was, this was our very initial time, we didn't have many experiences, so we just left this alone, didn't approach the area, and went ahead and did a surface ablation after the original edema subsided. So you should use the correct technique, and you should use your brains to decide whether you should want to go ahead or not, and not just try desperately to finish the procedure, because ultimately for the patient it's the result which matters. And so you should not really compromise in any corneal refractive surgery, and just in order to finish the procedure. I'll just take one more minute. Sometimes you have lenticules stuck under the flap, and that can create a problem. But Dr. Ramya very nicely showed how you can remove it. You also have rescue instruments like this, which can help you to, like a rake, which you use to remove the leaves from the ground. You can actually separate the lenticule and remove it by finding the plane on the other side if it's not close to your incision site. Other complications has been pointed out. You can have lenticule tags remaining behind. You can have materials like eyelashes, fiber, foreign body, mucus in the contact glass cornea interface. If you find that on docking, there are areas where you are finding these things stuck under the contact glass, you should just stop the suction, clean the whole surface, clean your eye, dry it, and then redock. If you need to, then just change the contact glass, but don't go ahead with a dirty one, because that would lead to a lot of black spots, and it would lead to a very difficult separation. Post-operatively, sometimes you can have fine interface haze, and here there is a big role of steroids. You can just give potent steroid. So something like a prednisolone acetate eye drops given in a higher dose for a short period, and this will clear the slight haze. Sometimes there is persistent dry eyes, especially if the person is a chronic contact lens user and already had dry eyes, and it should be treated as such. And even though you are actually leaving the cornea much stronger, there have been cases reported of ectasias happening even after smile. So you should be very careful and not really go and delve into this gray area of having form-fristic keratoconus, thinking that it's still safe to do this because you are not creating a flap. Thank you very much.
Thank you, Dr. Rupal Shah. Of course, in any procedure, the potential complications can be varied, and the approach to correct each one of them can be different. So we've covered the most common complications. Trust me, if you're a meticulous surgeon following all the protocols, you probably won't see any of these. Rupal Shah seen everything because she started very early, and she had machines that were completely, if you look at it, were dinosaurs compared to machines of today. So none of these you're going to see, so don't get worried looking at these complications. So we have Dr. Aditreya now going to talk from one extreme to the other. The latest step up of Smile, which is the Smile Pro 800, which makes life far more simple and the results to be far better. On to you, Aditya.
Yeah, morning. So I'm just going to talk to you about the latest update in Smile now. It's called the VisionMax 800 machine. And so the procedure itself is called Smile Pro. So as we know now, Smile is now an established modality in the correction of myopia and astigmatism. You can correct myopia up to 10 diopters, astigmatism up to -5. So the new update of Smile has significant advantages. The quickest update is that it only takes 8 seconds now for us to finish the laser application. So this will significantly reduce your chances of suction loss happening once the laser application starts. Second advantage is now that the cyclotorsion compensation that was absent in the older machine is now been incorporated in the newer one. So in case your patient has a significant amount of cyclotorsion and they have a high cylinder, the treatment effect will not be compromised. So as we know, these were the drawbacks with the older machine. Here is a video of the docking with the VisionMax 500. As you see here, one of the disadvantages was it was not very easy for you to make out the pupil center when you're docking. Until the cornea is very close to the contact glass, you couldn't really make out the pupil center. One would have to make an educated guess as to where the center is and ensure that the pupil is right at the center of the treatment application. So now as we see here, the laser is about to start. Laser takes 22 to 30 seconds in the 500. As we see here, this is the posterior cut. This is the scary part. Now the patient cannot see the green dot very clearly anymore, and then this is where they start to become a little uncooperative. So this is when the anterior cut happens. This is when you have to hold your breath and instruct the patient to not make any sudden movements and keep both eyes open to ensure that there is no saccades happening. So this is the new machine. The difference is now the two arms move up and down. The bed doesn't move per se. The bed remains static. You'll have to bring the first arm down first for the laser application. And once the application is done, you can bring the second arm down for the lenticule dissection. So one can actually modify this technique and go about it whichever way you wish to. You can finish the laser application on both eyes and then move to dissection for the both eyes. But what I do is usually tend to finish the laser application on the right eye first, move the arm up, bring the second arm down, finish the dissection, again switch the arms again, laser application on the left eye, switch then do the dissection. Reason being is I don't like to keep both eyes open for a long time. The cornea gets too dry. You can have epitheliopathy in the post-op period. So this is my preferred technique. So again, these are the advantages. 8 to 9 seconds of laser application. Pupil centration is very easy to do now because now in the heads-up display of the Smile 800, you can see a guide as to where exactly the pupil center is. You can even enter the pupil coordinates on the X and Y from a topographer machine. If you have the Sirius, those coordinates will match up with the 800. It tells you where exactly the pupil center is and you can dock in the correct accurate position. So cyclotorsion is also addressed here. This is an external view of the 800 docking. As you see now, the docking arm is is seen given to you in an external monitor. It's not that you have to look into the binoculars anymore. As now you see that the external monitor, you're able to very clearly make out the pupil center, and there's a guide. You will see the yellow line there. It tells you to move towards that yellow line, and once you dock on the yellow dot, that is where your pupil center is. So you can map out the coordinates exactly, and once you activate suction, you can start the laser application. It only takes 8 seconds now. So posterior cut is over. That's about 4 seconds, and now the anterior cut is done, and that's your side cut. So that's all it takes to finish your laser application in the new 800. So this is the docking, which is seen through the video recording of the VisionMax 800. As you see here now, you can very clearly make out the pupil center. It's very visible to you, and go ahead and dock. So we are bang on the pupil center now, and once we turn on suction, laser application begins. This is now being shown in real time. So you see it's very fast to finish the posterior cut, side cut, and now the anterior cut. And this is the incision opening. That's about all. The rest of it is quite standard. This is the dissection technique that I usually use. The other advantage now is the optics in the VisionMax 800 are much better compared to the 500. You're able to see the planes very clearly. You can make out which plane you are in. A lot of times in the 500, you were more dependent upon your proprioceptive feedback that you felt at your fingertips, because sometimes the planes weren't very visible to you. The advantage in the 800 is, since the microscope is so much better now, not only can you feel the resistance that you need to feel at your fingertips, you can also see very clearly which plane you are exactly, and go ahead and finish a dissection quite fast. So this is just a standard dissection technique. I'm not going to dwell too much on it because, as you know, the other two speakers have covered it very extensively. So this is a study we have done comparing our outcomes between the VisionMax 800 and the 500. So what we did was we had 72 eyes in one group and 72 eyes in the other group, all of which were compared by the standard methods of refractive surgery reporting as recommended by JCRS and ACRS. So group A were patients who undergone SMILE with the 800. In group B were patients who undergone SMILE with the 500. Inclusion criteria and exclusion criteria are all standard for refractive surgery practices. We use the method of getting best correction and standard corneal topography, and all of which were done. And all patients were above 18 years of age with good topography and standard refractive stability for the last 1 year. So patients with the group 1 treated with the VisionMax 800, they were marked preoperatively with the limbal markings in the slit lamp. We marked the 0 to 180 degrees using a needle. And once the patient was shifted to the operating room and they were made to lie down, we use a gentian violet marker to ensure the 0 180 degrees were made more visible. And once the docking was done, you can go ahead and incorporate a circular torsion compensation. Whereas in the VisionMax 500 group, we did not incorporate the circular torsion technique as it's not really recommended by the company. So these were the comparison of the preoperative parameters between the two groups. As we see here, both the groups had no significant differences in the preoperative sphere or cylinder. Here are the results with group 1 with circular torsion compensation. You see here that the results are quite fantastic. The spherical Lecunda refraction was quite good. All patients were within half a diopter of sphere after the procedure was done, and the results were stable for 3 months. And refractive astigmatism is where the SMILE 800 really scores. As you see here, about 100% of patients were within half a diopter of cylinder. TIA and SIA were quite close to each other, and here is where we saw a difference in the angle of error. All 85% of the patients were within -5 to +5 degrees of angle of error. Very few patients were between 5 to 15 degrees. And this is the results of group 2. This is the patients with the VisionMax 500 treatment without circular torsion compensation. Again, there were no lines lost, but you see here that the cylinder treatment is a little worse compared to the VisionMax 800. As you see here now, in the angle of error, when we look at that, still 88% of patients were within 5 to 15 degrees, but there were some patients who had angle of error between 15 to 25 degrees. This is the vector graph analysis. As we see here, this is the difference between target astigmatism and surgically induced astigmatism. That is the amount of astigmatism treatment that you intended to treat the patient with. The first group, the vector mean is only 0.22, whereas in the second group, with the VisionMax 500, the vector mean difference was 0.37. So it is a little more accurate with the VisionMax 800. And this is the comparison of the post-operative parameters between the two groups. Sphere was very good, but VisionMax 800 scored a little better. Cylinder, again, the VisionMax 800 scored a little better compared to the VisionMax 500 group. But when you look at the comparison, there was no real significant statistical difference. The VisionMax 800 group, the difference was patients actually gained 1 line. There are a few patients who gained 1 line and a few patients who gained 2 lines in comparison to the best correction. Whereas in the 500, there was no gain of lines per se, but there was only 2 eyes which had a loss of 1 line. The main difference is the post-operative cylinder angle of error was less in group 1 with circular torsion compensation in comparison to group 2 without the circular torsion compensation. So I conclude by telling you that circular torsion compensation in SMILE gives you slightly better results when treating myopic astigmatism. Your rates of suction loss will be considerably less because the laser application time is only 8 seconds now. It is an improvement over the older generation. But again, one need not be disheartened that you have to only invest in the newer machine. When you really look at the publications, we know that the amount of cyclic torsion that occurs in 90% of patients, so it's only 2 degrees. So that's not really much. It won't compromise your results in more than 95% of your patients. But when you do have that small percentage of patients who have a high cylinder and they have a higher degree of cyclic torsion, that's when your results can be compromised. One way to minimize this is to instruct your patients before the procedure begins that they should not squeeze down on the speculum, they should not try to close your eyes forcefully. When they do all of this is when the eye can cyclotort and you can have compromised results. As long as you reassure them, give them the proper instructions before the procedure, you can really minimize the chances of this happening and still give your patients good results if you still have the old machine as well. And thank you for your attention.
Thank you, Aditya, that put in place the advantage of the 800. Though the results of the 500 are brilliant, that icing on the cake and the cherry on top of that can be got by the 800. So it's really useful. Now for the very awaited talk by keynote address by Dr. Sharon D'Souza. So this is the Shiv Prasad Hadya Award. She's going to talk to us on the effect of cap depth in SMILE on clinical, biomechanical, and molecular outcomes.
Good morning, everyone. I think it is my honor to be a part of this session. Those were very, very nice talks, very interesting. I think I learned so much. So I thank all of you and the AIOS for this award last year and to make me a part and allow me to present it again here. So I think after hearing those wonderful talks about SMILE, this is a little, just a concept, because we know that the SMILE cap can be made at various depths. And there are some papers which suggest that you can do it at 100, 150, 160. But is there any reason to choose between those? Is it just the refraction that we're looking at, curvature, or is there something more? And does it really make a difference to our outcomes in general? So we know that one of the things that the cap or in any incision in the cornea can affect is the nerves, because our subbasal plexus of nerves run just below our Bowman's layer, which is around 50 microns and extends to about 30 microns beyond that. So we know these nerves are very, very important for the sensory and reflex functions, our tear secretions, the sensations on the cornea, and also wound healing. So they do maintain the ocular surface health. When we do a SMILE or any refractive surgery, even in LASIK, there is certain transection of the nerves. The good thing is that in SMILE, because the incision is much smaller and the cap then is below, the amount of nerve transection is less for sure. But unfortunately, it is not zero. So there is definitely some effect that happens because of the SMILE surgery. Again, it has been shown that once the nerves are transected, there is a reinnervation which happens, and this is definitely higher than other refractive surgeries, but none of them actually recover to a full degree, and it varies a lot. So we know that the SMILE cap depth could have some effect on the surface inflammation, but does preserving it, the corollary, is it true that if we go that extra mile to try and preserve the nerves, would it then help us in any way? So that's what this entire study was. So the knowledge gap is that we know it can affect all of these, and we wanted to put it all together to try and see how it actually looks at our outcomes in a clinical scenario. So what we did was we took patients who were planned for SMILE, a regular SMILE surgery. Of course, the usual exclusion criteria for these refractive surgeries were followed. It was prospective interventional, and it was a contralateral eye study. So one eye had a cap depth of 100 microns, and the other was 150 microns, and 40 patients were chosen. The refractive workup, the preoperative workup remained exactly the same as we do for SMILE surgery, but we made sure that we also had an assessment of their optical quality, which was very important because we need to see it post-op, detailed dry eye evaluation, and molecular factors to see if the inflammation on the surface had changed. All of these surgeries had all the parameters exactly the same in both eyes, same surgeon, same parameters, and same diameter, and except for the depth differences. So the various outcome measures which were looked at were, of course, the visual acuity and the quality, because we know that scatter can be there if there's a lot of scarring. We looked at the nerves pre and post-operatively, how is the epithelial mapping changed, and looked to see if there's any nerve degeneration in these patients, and also if their dry eye parameters changed. And this was recorded pre-operatively 1 month, 3 months, and 6 months. Very interestingly, we found that even though initially there seems to be a lesser reduction in the Schirmer score at 1 month in the 150 micron group, by around 6 months or so, it comes back to near normal, and both groups seem to do almost the same. Again, similarly, there was no significant difference when we looked at their vision, both the quantity and the quality. The optical outcomes were also very comparable, all through in both the cap depths. So till now, we are feeling quite reassured that we're not doing any damage with either. Again, even in the corneal biomechanics, both the 100 micron and 150 micron cap depths were comparable, and there was no problem. The difference came here. When we looked at the nerve regeneration, the 100 microns cap depth at 1 month, if you see the second confocal image, there seems to be, very few nerves that are visible, and this was seen across almost the entire group. But reassuringly, by around 3 to 6 months, this does regenerate. The 150 micron cap depth did slightly better, so there was less transections of the nerves, which is logically, what we would expect. It's a deeper cap, so it doesn't affect the subbasal plexus as much. But of course, by around 6 months, they're all coming back to near normal. The inflammatory cytokines again was the converse. In the 150 cap depth, it seems that there's a slightly increase in the amount of inflammation that is generated, and also the extracellular matrix modulators are altered a little more. What this would imply to us clinically or logically, we would expect that then in those patients, we may have some amount of more scarring if we don't handle it better. So this is a summary of what we found, where there was not really that much of anti-inflammatory or pro-inflammatory changes, but the extracellular matrix factors did show a change. So would it affect our wound healing response? As I said, there has been some excellent work before trying to look at different cap depths, and we wanted to put this all into one umbrella to try and understand what we have. So at the deeper cap depths, we found there's earlier nerve regeneration, faster recovery of the subbasal plexus of nerves, which was seen all through. The baseline parameters, does it matter? It seems that, over time, it all comes back to normal. By around 6 months to 1 year, we are looking at both groups doing fairly well. So what we're looking at is that the subbasal nerve density may not reach the pre-post-operative factors, but it is recovering fairly well. And most of them did recover their baseline levels at 6 months post-op. The deeper cap is very good, as effective in all other parameters, so there's really not that much to change it. How this applies to our results in the clinic is that when we are looking at doing a patient who needs a deeper cap for whatever our clinical reasons, since we know that they may have a little more post-operative inflammation, pre-operatively try to handle these a little better. If they have things like contact lens intolerance, dry eye, or any of these surrogate markers of an ocular surface disease, be a little more aggressive in treating it well so that we don't have any post-operative problem, because they may have some pre-existing disease. Thank you very much for listening.
Thank you, Dr. Sharon. So that was wonderful. So we have exactly 5 minutes for any discussion, any questions from the audience or any discussion among here. Now, we don't have Dr. Sheetal, who was supposed to talk to us about hyperopia. Maybe I should ask a few questions to Dr. Rupal about the hyperopia treatment in SMILE and how soon we can expect to have it.
So we had the chance of doing some hyperopic patients, about 100 eyes more than 10 years ago, and the results at that time was also quite promising for hyperopia up to about 4 diopters. Beyond that, anyway on the cornea to do a hyperopic treatment usually doesn't lead to very stable results and leads to a lot of aberrations. So results were comparable to LASIK. And I was actually expecting it to be released quite soon after that. But there are newer parameter settings. And of course, now with 800 Pro, they need to do some more studies with the newer lasers to release hyperopia along with because all the studies were done with the older lasers. But they can actually transfer the data and work on the Pro 800, Visumax 800 much faster. So I think it should be there in the next year or so. Having said that, hyperopic patients are not a big chunk of what we do in terms of refractive surgery on the cornea. And therefore, right now it's still worth to do the SMILE procedures and to have it included in your armamentarium, because it's fast becoming the procedure of choice. So you should not be really be left out of this wave of SMILE.
Actually, there's some indication that they're going to release it in about 6 months or so. But believe me, they've been telling 6 months hyperopia is in the pathway for the last 8 years. So that's a different story. But this time they're possibly going to come out, and probably in a year to 2 years, we should have mixed astigmatism also. Somewhere about 1 year to 2 years from now, we should be having the Presbeyond available on this platform. The third one is they're going to come out with some kind of customization also. So now I think they're going to come out purely at a faster pace, not because suddenly they've woken up to science and other facts now that you're under commercial pressure, you have 3 other companies in the pathway and they're already marketing. So I think that would light a fire under the tail of Zeiss, and they're going to start doing things a little faster.
It was high time it happened. I also, there's also going to be Smile as a retreatment option for Smile, which has also been getting tried at several places. I have done a couple of cases. It did work well, but it does definitely require more work to be done on that. So that's where it stands today. I just had a small question for you, Karthikeya. Do you do any nomogram adjustment?
Not a nomogram per se, but what we do is for sphere, we overcorrect by 0.25, ma'am. So yeah, so we overcorrect all of our patients by 0.25. When you don't do this overcorrection, I feel the post-op residual is between minus 0.25 and minus 0.5. Yes. So, but when I overcorrect by 0.25, it lands between, post-op refraction lands between minus 0.25 and plus 0.25. So I feel that's a better result.
Ma'am, I have a question to ask you, sorry. So, as you rightly said, retreatment options for Smile. I personally believe lenticular extraction is the future of refractive surgery. So, creating a circle again which will weaken the cornea, I might not favor as a procedure of choice for retreatment. And with Dr. Sharon's presentation talking about the deeper cap there, when we talk about the retreatment Smile options, do we prefer within the Smile cap or something below the Smile cap?
So what I have done is considered the base, the stromal bed, as the posterior part of the lenticule, and done the anterior one. But because it was a very small myopia that we treated. What other people have also done is gone 20 to 30 microns deeper if they had a cap which was very thin from the base, and so that they don't go and approach the same plane again, and created another lenticule there. So that's why I was saying that it does require more treatment, more
studies
work,
too,
because it's not again as easy to calculate as what you would feel that okay, one diopter would not translate into one diopter because there are going to be two lens within the same corneas, two shape change. So how the rays would bend, that needs to be calculated. So it does require a very refined software to be able to do a smile on smile and not just feed in the data and do the treatment as we do.
So that's a different software which has to be incorporated.
That's why I think they are also going to have to work a little more on this.
Thank you, ma'am.
Thank you so much. I think we are perfectly on time. Thank you for the audience for being here. It was wonderful.